Good evening to everyone who is on our platform this evening. As I usually say, it's a Thursday evening today, 6 o'clock. So it means only one thing. It means the Clinix Health Group sponsored webinar for our colleagues. We've already got 230 plus. Some are still being let in from the lobby. So as they are coming in, they'll find us on the way. Thank you very much for making the time to be with us this evening. I think we really appreciate the interest and the keenness to learn from colleagues who volunteer to share their expertise with us every Thursday on this sponsored platform. The webinars are sponsored, have been sponsored for the last 5 years now. Time flies. By Clinix Health Group. Clinix Health Group is a company, private company that owns 8 private hospitals, most of them in Gauteng, got Northwest as well. And we really appreciate the continued sponsorship by Clinix for these webinars. The sponsorship makes us able to bring these webinars to you free of charge. So you don't have to pay anything. And just to also emphasize again that we have partnered with HPCSA so that our webinars are accredited for CPD points, both for presenters, but also for all attendees who have registered using their HPCSA registration number. So you need to register yourself to be credited for your profile with the HPCSA to be credited for HPCSA CPD points. If you are not a member of if you are not registered with the HPCSA, but with SANC, South African National Nursing Council, and also with Pharmacy Council or any other registering body, we are able to send you attendance certificates if you have attended, of course. There was a question, I think, Dr. Bikitsha, what about people outside South Africa, in Namibia? We've had people from Zimbabwe, as far away as Canada and the UK, who have attended and requested us for CPD points. We are able to send them separate certificates for those. But those who are registered with the HPCSA, you don't get a certificate. You get confirmation in your email in tray from the HPCSA directly, not from Clinix Health Group, that confirms the updating of your profile with the HPCSA with CPD points. The email usually arrives about 2 to 3 weeks after attending any of our webinars. During the presentation by our speaker today, you will be muted so that we don't interrupt him, but you will be able to type your questions or comments in the chat box, and the speaker will attend to them immediately after a presentation during the Q&A session. You will also be allowed to raise your hands, your electronic hands, at the end of the presentation if you want to make your comments or questions orally. I think that being said, if you'd like to communicate with us for anything, by the way, if you want to volunteer yourself to be a speaker in future, or you would like to recommend someone for us to approach that person to be a speaker in our future webinar, please contact us on webinars@clinix.co.za. Webinars@clinix.co.za. But even if you've got any query, any question, you can do that as well. We also, of course, often now and then send out surveys, webinar surveys to yourselves on the email addresses that you have used to register for our webinars, requesting attendees to please answer the few questions that we place for you to respond to in our surveys so that we can improve on this the platform. And your comments, your criticisms, your questions, points of clarity, I think you are able to do that either on the survey itself, or you can just write to us on webinars@clinix.co.za. Our speaker today, by the way, I'm Dr. Ernest Kinoshi. I hope you can see that. I should introduce myself. I've been with Clinix for a number of years now, over 8 years. But our speaker today is one of our, we are proud to present her, one of our young specialists, enthusiastic specialists. She's a specialist pediatrician, Dr. Nomthandazo Bikitsha. Dr. Bikitsha is dedicated pediatrician committed to improving child healthcare, especially in underserved populations in our country and beyond. She holds an MBCHB from the University of Stellenbosch. She also has a DCH diploma in child health, which is with the Colleges of Medicine of South Africa. She attained her MMed PEDS from University of Free State. And she's got FCP PEDS as well, also from the Colleges of Medicine of South Africa. She was rotating through Universitas Central Hospital and Pilonomi Provincial Tertiary Hospital. She has also got a certificates in life support, basic life support, but also in advanced pediatric life support as well. Dr. Bikitsha is passionate about collaborative healthcare initiatives and advancing projects that expand access to quality pediatric services across Africa. She's also participated in outreach programs, including the Africa Impact Medical Volunteer Program that focused on infectious diseases in children in a district in Limuru in Kenya, with special interest in HIV and tuberculosis. Dr. Bikitsha is also part of a religious organization called Burning Bush Ministries and has been part of their national structure that focuses on children ministry. And I'm proud to introduce to you Dr. Bikitsha. Over to you, Dr. Bikitsha, for your presentation.
Thank you. Thank you so much, Dr. Kinoshi. I think I am going to be quick, but I would like to be clear. So if there's any interruptions in the presentations, please do inform me before I just rush over to the finish line. But nonetheless, the presentation for tonight, or rather this evening, is going to be reviewing, or rather looking at the surviving sepsis guidelines that have been reviewed and released in March of this year, of 2026. We're going to look at the history, which I will give after this. According to the World Health Organization, in 2020 alone, they noted that sepsis, or rather cases of sepsis, were almost 50 million, with 11 that caused death, that was septic-related deaths. Out of these cases, 20 million were attributed to be cases of children under 5 years of age. So this shows that sepsis does significant, causes mortality significantly in your maternal, neonatal, and children. Therefore, when you look at your sustainable developmental guideline goals, rather, for 2030, so combating sepsis would be achieving not only one, but 3 of these guidelines, not looking at your, obviously, co-funding factors that contribute to the onset of sepsis, and also risk factors like your vaccine coverage that will predispose you to severe forms of disease. Then if we look at the terminology that is used in this guideline in trying to describe the term sepsis and septic shock. So sepsis is defined as an infection leading to a life-threatening organ dysfunction, including a patient with septic shock. While septic shock is when you have inadequate perfusion or cardiovascular, which is and/or cardiovascular dysfunction, not necessarily attributed to a cardiac pathology. Then your probable sepsis would be a clinical case that is consistent with sepsis where there is no confirmed culture or infection as yet, while suspected septic shock would be shock where the etiology is not confirmed, but it is mostly suspected to be secondary to infection. Where septic shock with persistent hypotension, I think these terms are going to come into play when we look at the statements and analyzing the statements. So it's just to keep them at the back of our minds. So septic shock with persistent hypotension is your then sepsis with ongoing signs of hypoperfusion despite initial treatment. So if we look at the history of the guidelines, so not necessarily looking at the history of guidelines themselves, we would note that there were no pediatric specific definitions of sepsis up until so management of sepsis in children was usually stipulated from adult data, or rather data that was released out of studies that were done in adults. Then in 2005, the International Pediatric Sepsis Consensus Conference was held, and this is where we see that sepsis was then defined as SIRS response with a suspected infection. Then it would depend on the severity when you trying to say, is this now septic shock? However, towards 2014, the Surviving Sepsis campaign in pediatrics started looking, trying to narrow or rather focus more in the pediatric population, and also noting that SIRS was not really specific to sepsis because the number of non-infectious causes that causes a SIRS response. So this was then modified and kind of toned or pruned to try and become more polished in terms of having guidelines. Then in 2020, this is when we had the joint effort where the first Surviving Sepsis campaign guidelines were released. And this was a joint effort between your Societal of Critical Medicine, of Critical Care in Medicine, and European Society of Intensive Care Medicine. Then in 2026, in these guidelines, there's 20 new statements, of which you will see that there will be written in yellow or gold, depending on how you see color. Then there are 19 statements from the previous guidelines that were revisited, which will be in this blue color. However, only 13 were updated, and this was based on whether those statements needed to be clarified or there was new evidence that came on board, and therefore you would see that the recommendation would either be stronger or would still be like a conditional recommendation. Then out of the 19 that were revisited, only 13 were updated, then the 6 fell into the 22 that remain unchanged. So in order for us to be able to follow tonight's presentation, I want us to create a mental picture depending on how you study or you view things. You can either follow the flow of patient assessment. This is a primary caregiver who's bringing you, or rather bringing a child who is unwell. So it will start with you as a clinician looking at, could this be sepsis? So this is now early recognition. Or could this be something else? So you're looking at your triage, you're looking at the protocols that are involved that are bringing awareness, even in your pediatric trained staff that will be able to pick up that this is sepsis. Then you need to now prove or maybe take tests that will show this is sepsis. So these are your molecular studies or your PCRs for genetics, which you will see that it's the new added statements or your blood cultures, um, and the timings of your antibiotics because you're now treating your sepsis. Then when you treat your sepsis, this is where the concept of antibiotic timeliness is going to come in and the type of antibiotic that you're going to use. However, when you see a patient, you first will then clinically assess. You say maybe that you recognize this as sepsis and you want to take bloods or cultures or molecular studies or prove the type of sepsis that they have. Then you start your antibiotic or antimicrobial rather therapy to try. Then you must assess, is this patient shocked or not? If they are shocked, there's a fluid therapy sort of recommendations that we're going to look at. And if they're not shocked, there's also the maintenance sort of therapy that you're going to look at. If they are shocked and they not responding to fluids, do I need to start something? This is where we're going to be speaking about our vasoactive agents that you need to start or rather manage and the choices that you're going to make in terms of choosing that vasoactive agent. And then you will assess your response, obviously. And if they're not responding, then it touches things like immunotherapy, so suppressions of that, any other what is this metabolic sort of endocrine involvement, and some other things that would uh, assist you in terms of getting better perfusion. Then you would reach the states of any other organs that are involved, and if they're failing, and how you're going to manage those other organ dysfunctions. And then obviously you reach the state of long term and follow up if there is recovery from that sepsis. So you can follow it in that way, and that's how the presentation is going to go. Otherwise, if you're very like one headings, then you can follow the subheadings as well, and then you can follow the presentation in that format. So, as we have mentioned, so it starts with your primary caregiver that will notice that my baby is not well or my child is not well. And these guidelines are varying from your infants after 28 days up until 18 years of age in terms of covering. So, when the child comes into contact with the clinician, they will be, if it's a sector that is well familiar or has sepsis or other infection control measures in place, there could be policies in place, there could be protocols and guidelines, and also procedures to follow if you are suspecting sepsis, and divided obviously to those different age groups. And then depending on the healthcare sector as well, there could be certain protocols on this is what you do in the first how many hours, and then these are the tests that you do depending on the lab services that are on board. So if we look at the statements themselves, the first one, it's obviously emphasizing that recognition and management of sepsis. So it says in children who are acutely unwell, there's insufficient evidence to recommend implementing systemic sepsis screening. And this was based on the studies that were done to show apparently 5 observational studies that were analyzed in one random control trial that was analyzed to show that systemic screening of all children did not really benefit to less mortality or better antibiotic timeliness or hospital stay that was shorter. However, they did note that these studies that we analyzed were already done in establishments that are well established in the quality improvement initiatives when it comes to sepsis. So for them, screening was already kind of taken care of in terms of the initiatives that they needed to do So the panel did acknowledge that alternative approaches need to take place in maybe uh, for appropriate different healthcare context. Then the second one that was noted was they recommend hospitals should uh, implement a performance improvement program, including standardized operating procedures. This was a strong recommendation where there was no evidence. However, the strong recommendation came from noting that, or rather analyzing observational studies, that it did show improvement in terms of outcome. Because if you have quality improvement programs, these are your protocols, these are your guidelines that are in place in managing sepsis, or rather triage things that are in place in screening and managing sepsis early, it improves recognition and therefore will improve clinical management and therefore will improve outcome in that sense. Then the third statement, for those with probable or suspected septic shock, they recommend measuring blood lactate as part of clinical evaluation and management. And this was a strong recommendation. But however, in this argument, they did say that measuring lactate is of more value in the resuscitation phase, because in the several studies that they looked at, they realized that elevation of lactate was associated with high mortality. And the Phoenix criteria came into play here because it noted that with your high lactatemia, especially over 5, already you get your cardiac dysfunction with hypertension and onset of vasoactive medication. Once you have a Phoenix score of more than 2, then you fill in the criteria for sepsis. So the higher your lactate, as in the Phoenix score, so it starts with 0 points if it's less than 5, and then between 5 and 10, you already get 1 point, and then up until 3, and then with lactate of more than 11, you get higher points. So, and you need just 2 in the score of the Phoenix score to fit in. Then the fourth statement was, which was unchanged, is that there should be no delay in starting antimicrobial because of blood cultures. You should obtain blood culture before initiating, but it shouldn't delay your antimicrobial administration. And number 5 was one of the new statements where it admitted that there is routine molecular testing available now, which has a potential benefit of rapidly identifying pathogens because it's PCR based and it's quicker. And you could also look at your resistant genes on the get-go, or rather at the point of admission. However, the concerns were that this could work for your high-income countries and not necessarily your middle and lower income countries because of the resources that are required in implementing these measures across various epidemiologies. Then number 6 to 7 was looking at antimicrobial therapy. It's actually up until 16. So they looked at the when, as in the antibiotic timeliness, what, as in which cover should you give. And I think one of the new points was when giving the antibiotics, whether it should be the intermittent dosing, the extended dosing, or the continuous dosing, and evidence on that, and also when to stop and how to monitor response to the treatment. So in number 6, the statement was that if you suspect septic shock, they recommend that you should start antimicrobial therapy within an hour. But however, if it is probable septic without shock, then you should start antibiotic within 3 hours. Where there is a probable bacterial sepsis where you think it could be, there isn't obviously a positive culture. Here they say you could continue looking for, but it shouldn't delay. They say you should consider giving antibiotic as soon as possible. There's a big cohort study, which was a retrospective study that they noted here, which was done in America. It was a multi-centered study with almost to 20,000 children that were analyzed. It was 19,515 that were analyzed in terms of antibiotic to try and prove that delaying antibiotic will increase mortality. So the compared these two groups of those who were given antibiotics within an hour, the mean was around 69 minutes, and the ones that were given in less than 330 minutes, which is about 5 hours and 5 hours and a half minutes. And obviously, there was a higher mortality within the ones that were given antibiotics late. So basically, this is just a extrapolation of the key points from that study. So they were assessing the timing of an antibiotic or whether the timing of giving antibiotic had an effect on the outcome. So if we look at number 9, it starts by saying if you are suspecting, you must start with a broad empirical cover to cover your likely pathogens. However, in your immune compromised candidates or patients who are at high risk of multi-drug resistant pathogens, you should, they suggest using a multi-drug therapy, even though there was low quality evidence in this one. Then I think this is becoming more and more common now, especially in our intensive care units, where this is a new statement where it says for children with confirmed bacterial sepsis being treated with a Bikitsha antibiotic, there is insufficient evidence to recommend for or against routine, continuous, or extended infusion strategy as compared to intermittent dosing. So they noted that there was a clinical trial that was done in adults that showed that there was a small mortality reduction for the ones that had an extended infusion. It wasn't a continuous infusion and an extended at day 90 of life. There was a small mortality reduction. However, for pediatric data, it's still limited and still remains inconclusive. However, I think the school of thought is now looking at the pharmacokinetics and pharmacodynamics and obviously the mechanism of action of drugs and how others are dose dependent and others are your MIC needed. So if we are now completing towards the antimicrobial therapy heading, there were 2 statements that were not changed at all, which was for those with once there is susceptibility available, meaning once the cultures are out and the pathogen is known, empirical antibiotics should be covered, should be narrowed basically to definitive management. And if there is no pathogen identified, the clinician should narrow or stop the empirical antibiotic therapy according to clinical presentation. And I think this one is one that we practice in most settings as well. Then 3 new statements came off, which for children with septic shock, which are treated with antimicrobial therapy, they suggest not using PCT as a de-escalation strategy for therapy. However, this was based on the fact that there wasn't any much of a difference in one neonatal and one pediatric randomized controlled trial. They advocated for antimicrobial stewardships. And you would see the following 2 statements there. One is for those with septic shock with a proven bloodstream infection, they suggested routine infectious disease specialist or medical microbiologist consultation in the management for advice. And they say in the observational studies they looked at, it showed improvement in outcome in terms of mortality. However, if there is no documented bloodstream infection, there's insufficient. So it mainly depends on the setting, whether they still continue, even if there isn't, they still consult with your infectious disease a specialist or microbiologist. But I think the emphasis they made on these points was antimicrobial stewardship that should take place. And also, they were advocating more for infectious disease specialists than microbiologists. However, if both are available, you could, depending on what is available in your setting, and to consult with, as there was improvement in outcome. Then looking at source control, both the statements that were made in 2020 were not changed. So emergent source control intervention should be implemented as soon as possible after the diagnosis, and also removal of your intravenous access devices that are confirmed to be the source of sepsis or septic shock after a vascular access has been established. So those still remains as recommendations and were not amended. Then when it came to fluid therapy, I think I combined a number of statements here just to make it flow or rather easy to follow. And then you would see, we'll go back to the numbering just now, but here, if you have a child who you think has septic, or rather has sepsis, you're going to ask yourself a question: are they in septic shock? If yes, there are signs in keeping with septic shock, you then ask yourself a question: do I have a pediatric ICU? If yes, you are then guided to, you can give boluses up until 60 mils per kg, but at intervals of 10 to 20 mils per kg per bolus. And there should be assessment after each boluses. You don't have to commit to the maximum. If there is response and you have given only 20 or you have given 30, you can stop it there, because you need to assess after every bolus. Then, if you do not have an ICU or pediatric intensive care unit, and yet your patient is in septic shock, you are restricted or rather limited to 40 moles per kg overall of fluid boluses, which you can give in 10 to 20 moles per bolus, with assessment after every bolus. Then, if your patient is not in septic shock, you still ask yourself a question: do I have ICU available? If you do not have ICU available, they say not for fluid boluses, but you can go for your maintenance, your IV maintenance. Then the type of fluids that you give. So obviously this was that point of view, must assess after every bolus. Once you choose a path to follow, you don't commit to it even if there is clinical response. Then the type of fluid that is used, obviously crystalloids are more preferred than your colloids, and then your balanced crystalloids and buffered crystalloids are preferred than your normal saline. And I think they didn't really go into detail in time, because these were statements that were not changed. They were carried on from the 2020. However, the fluid extension as supportive therapy trial explained the differences in terms of when you use your colloids and your normal saline, the sort of complications that come into play when using those. Then for hemodynamic monitoring, there were a few sort of new statements. I think the two, 25 and 29, but you will see that number 25 is a repetition of when you were given the fluid therapy, because they say resuscitation of children with sepsis or septic shock should be guided by ongoing clinical assessment, and you can use your normal heart rate, blood pressure, capillary refill time, extremity temperature, pulse quality, level of consciousness, and urine output. And then for those with no, or there is insufficient evidence to use the target mean arterial blood pressure, they did suggest using central venous oxygen saturation of more than 70 if there is a central excess available. And there was insufficient evidence in recommending using advanced hemodynamic monitoring tools for bedside clinical signs to guide resuscitation. However, the point of care ultrasound is being advocated for, and it became a news, especially for resuscitation. It became a new statement that was added that it is suggested that cardiac and lung point of care ultrasound to guide resuscitation is of benefit over not using. And if there could be trainings or resources allow, they advocate for that because they said it augmentates your clinical assessment for reversible causes that you can reverse during a resuscitation and therefore aid to better outcome in that way. Then for vasoactive medications, there is still insufficient data or rather evidence to issue a recommendation of starting vasoactive medication either before or after the 40 mils. Remember when you were following the fluid bolus, if you did not have an ICU, you were capped up until 40. However, they still say there is not enough evidence to say then you can start vasoactive medication. Then for those requiring vasoactive medication, there is still also insufficient evidence to say they would rather choose between epinephrine and norepinephrine as first therapy in children. And I think they did note a study here. It said that I didn't really have time to go into details where they were comparing the study that was done, comparing both your adrenaline and noradrenaline to see if there was a difference. Then for children with septic shock requiring vasoactive medication, they suggest initiating with peripheral. You do not need to wait for a central line, basically. You can start peripheral strength and use a peripheral venous access over delaying therapy. And there was a study here that they analyzed where there was improved in mortality for those who had peripheral strength of your vasoactive medication, rather than in comparison to those who had to wait for a central line in order to start a vasoactive medication with central strength. So there was improving mortality for those who were started. Then these two following statements were unchanged. These are for those who require high dose of, you are in shock and you're still requiring high dose of catecholamides. They suggest either using or rather adding a vasopressin or titrating. And those who are still in septic shock and cardiac dysfunction, despite your treatment, there is insufficient data in adding an immunodilant. So this is your dobutamine or milnirone. There is insufficient data in that in adding. Two statements that we knew for vasoactive medication is your children who are in septic shock with persistent hypoperfusion despite treatment with vasoactive medication. They still noted there is insufficient data in using your angiotensin 2 in trying, obviously, for the vasopressor effect, or using methylene blue or core treatment with methylene blue in aiding your, or rather aiding or restoring oxygen carrying capacity. So there was insufficient data in using any of the two. Then when you look at ventilation, only one statement was new. The two remained unchanged. It's a child who is fluid refractory in terms of shock. They are catecholamine resistant and they do not have respiratory failure. There's still insufficient evidence to whether to say you are going to intubate. Then a second one is a child who is shocked or rather in septic shock with sepsis. And now you need to intubate for an induction agent. They are suggesting against the use of etomidate because of your adrenal suppression and therefore worsening shock, even though it doesn't really cause remarkable changes with your blood pressure. Then the new statement was for the intubated ones, following your septic shock, following your resuscitation, they suggested a titrated supplementary oxygen targeting a conservative range, meaning your saturation, you're targeting around 80 to 92, other than the liberal approach of aiming for 92 and above or 94 and above. And in this one, they analyzed 4 random controlled trials and showed that there was actually shorter ventilation time or duration for the ones who had the conservative range with a shorter ICU stay, but it also had shorter lung injury with the ones that have the conservative range in saturation. Then, when it comes to corticosteroids, there was nothing new added. However, they were just analyzing the use of hydrocortisone. There was still, the first statement wasn't changed, where they suggest against the use of, if you are in septic shock, with where the hemodynamic stability can be restored with fluids. They suggest, or rather, they are against the use of then using hydrocorticosteroids. However, for those who remain hemodynamically unstable, despite your fluid resuscitation and vasoactive therapy, there wasn't sufficient data to recommend hydrocort. However, it still wasn't contraindicated because they noted that you could still be in a state of adrenal insufficiency and therefore it has a role to play. Then for endocrine and metabolic, so it was noted that there wasn't sufficient evidence for whether you're aiming for normothermia or permissive hypothermia, or rather allowing a bit of a fever, as it's a normal immune response to the sepsis itself. However, they did note that for use of sodium bicarbonate, there's still no sufficient data to say they could recommend in your severe metabolic acidemias. Then for children with septic shock with, or for targeting your calcium levels and also your treating your sick euthyroid state, also not insufficient data to say whether we're going to target normal calcium levels and you must treat or rather tolerate hypocalcemia, or treating the sick euthyroid in order for you to have a normal thyroid levels. So they were against the use of treating. Then further on on nutrition, I think these were just supplementaries. It's statements that were not changed. I think some or one or two were reviewed, but they were not changed still. So they're against any use of vitamin C, thiamine, or replacing any vitamin D if there is no deficiency or rather insufficiency. So basically, any supplementation were not, there wasn't any evidence actually to show that it helped. When it came to fluid balance, renal replacement, and extracorporeal support, um, it is a reasonable to consider measures to prevent excessive fluid administration. Therefore, they emphasize on your active fluid removal if there was a state of fluid overload, but more so it was close monitoring in order to avoid a fluid overload state. And then for children with sepsis who are requiring renal replacement therapy, they suggested your high volume hemofiltrations over the standard volume hemofiltration. Um, then for those with a thrombocytopenia associated with multi-organ failure, there isn't sufficient evidence to treat with plasma exchange. However, one of the new statements, it was the ECMO that was added, or rather added statement where they said there is insufficient evidence to issue a recommendation. However, they did differentiate, and I think these two statements were unchanged from the previous ones, that they actually prefer your venous ECMO over your renal arterial, but the renal arterial could be used as a rescue therapy. This is when you're having now refractory hypoxia. Then for immunotherapies, so for children with septic shock, there's still insufficient evidence to recommend tapering or discontinuing your immunosuppressive therapies. This is a child who is maybe under a certain immunosuppressant because of maybe an autoimmune disease. So the main concerns here were that of disease progression, that you're going to stop the immunosuppressive therapy and then the disease will progress. And then they were against the use of any immunologic or IV or what is this now? Polygraph. I'm sorry, it just went through out of my mind. For children with sepsis or septic shock, with evidence of leukopenia or immunoparalysis, there is insufficient evidence to issue a recommendation on the use of immunostimulants. Also, so for those with hyperferritin, there was insufficient evidence to use any immunosuppressive therapies. Then I think towards the last statements, which was the long-term follow-up, I think here they noted your psychosocial and neurobehavioral and cognitive mobilities that came after sepsis, especially once the children came into the adolescent stage. So there were a few new statements that came into play. They suggested implementing individualized and early rehabilitation during the acute illness rather than waiting during that state where they're still in acute state rather than waiting for later. Then for post hospital follow up, there was insufficient evidence to actually recommend a post hospital follow up. However, they did note that children who survive sepsis suffer not only just the initial sort of hemodynamic instabilities, but they suffer from physical, cognitive, emotional, and social sequelae that persist for months, 2 years after being discharged, or rather recovering from sepsis. Therefore, they still advocated for a structured follow-up program, so as to improve the mental health for both the child and the family. Then of last, it was your assessing the risk factors for post-sepsis morbidity, educating the patient, family, and clinicians on the symptoms and post-sepsis mobility, and also evaluating for new and long-term sequelae after hospital discharge. And this is where they discuss some of the neurobehavioral and cognitive mobilities, especially with your adolescents that stay with the sequelae. And those are my references. And thank you.
Oh, thank you very much, Dr. Bikitsha, for a wonderful lecture. I think this was very instructive indeed. I think for all of us, you can see the applauses, the hearts, and the thank yous, the thumbs up on the screen, how many there are. I think we gained a lot from you. I mean, they've been at the top of the attendance. There were 571 people listening to you, which is great. I think this is the latest in the treatment of sepsis that we are hearing today. I think it's a good update, and I think I'm personally proud that you are one of us within Clinix. I think I didn't tell you that Dr. Bikitsha practices within Clinix Naledi Nkanyezi private hospital in the Val. She's got a full-time practice there, and she's become very popular in the area since she established private practice. And I think you can see the quality of healthcare that she dispenses there. And I'm proud, Doc. As I've said, and we've also put it in the chat box. You may put your questions and comments in the chat box, and Dr. Bikitsha will attend to them, will respond to them now. You may also, of course, raise your electronic hand. I see there's one hand already. And we will recognize it. You'll be able to unmute and put your question orally if you'd like to do that. Maybe let's start with the hand at the moment, Dr. Gulam. Ismail Gulam, you can go ahead. Please unmute yourself and raise your question or comment, please. Dr. Gulam Hussein, you can unmute yourself and put your question orally. You had your hand up. But whilst we wait for Dr. Gulam Hussein to ask, maybe you can respond to this one, Doc. I think you mentioned something about polygam. And maybe can you repeat what you said about polygam? Is it to be used in sepsis, chronic sepsis, or not?
So there is no evidence of I can even try and go back to that statement that supports the use of. We suggest against routine use of
polygam. Okay. All right. Thank you. And what about nutrition? We know that chronic sepsis is catabolic, especially for children, but for all of us. What about post periods of sepsis, especially if it's prolonged sepsis? What would you recommend for children?
In terms of nutrition, per se?
Yeah. Is there any recommendation for how you would, or maybe the weight loss that results from chronic prolonged sepsis? What would you recommend, or what any comments about it?
Okay. Thank you again for the question. I think on the guidelines themselves, I think they only mentioned your supplements that you usually add, your
Mm,
vitamin C, vitamin D, and your. However, rehabilitation, as mentioned, should start in that acute phase. Remember, you are coming in septic shock. You might have a severe weight loss, electrolyte imbalances. And therefore, when you even start the feeding process, you might be at risk of refeeding. So having a full team in terms of your dietitians in play and also supplementing, I think maybe a better way of answering would still be looking at the 10 steps
yeah.
of dealing with acute malnutrition. However, I do believe that they emphasize that rehabilitation should be during the acute phase because of issues of such.
Okay. That's fine. There's a question from Dr. Pauline van der Merwe, and she asked, just wondering, do we know how long since the start of infection it takes before sepsis can start? Or does it all depend on the host and the virulence, or rather the aggressiveness of the bacteria?
I think so, but in this study, the study that they analyzed, where they had a 19,500, they mentioned that giving antibiotics in less than 30 minutes is of no
Mm,
benefit. And the mean obviously was 69 minutes because at that point there isn't any virulence, there isn't. So I can't necessarily, I think it depends on the pathogen itself and how virulent it is, and obviously the host the immune system of the host at that point. But in this
mm.
study, they did note that any antibiotic timeliness and late we had high mortalities. So the means were between the 69 minutes and the 5 hours and a half.
Yeah. I see there's a post in the chat box from Dr. Ayanda Jolobe, who's who, hello, Ayanda. If you are still in London, please, uh, our best regards to you. Thanks for logging in. And Ayanda, you asking whether we are able to send you a copy of the slides. I think with the permission of the presenter, I'm sure we will. We'll email it to you. I think we still have your email address. Otherwise, you can send it to me. We will send them to you on permission of the speaker. That's our policy, but I'm sure we'll do that in due course, probably tomorrow. There's a question from Vuiseka Nsalu, who says, is there a way to distinguish sepsis from a typical infection using specific tests, such as infection or inflammatory markers, or is the diagnosis primarily based on clinical suspicion? When do you know,
So,
when do you say that there is sepsis or septicemia?
so there is suspicion. Obviously, I think if you look at the history, when they first decided that they were going to use SARS, which is your systemic inflammatory response syndrome, they looked at the fever, your inflammatory markers that respond, so your CRP or your white cell count that respond, and then obviously your hemodynamic status, so your blood pressure. But they used the clinical signs that are there when you're having a systemic inflammatory response. So whether we like it or not, those are still the clinical signs that we pick out to say there is suspected sepsis. However, you always want to, that's why there is source control. You always look for where it is coming from.
All right. The next question is from Dr. Matlante. My apologies. Is from Dr. Matlante, who asks, how do you handle, actually it's two questions in one, I suppose. Let's handle the first one. How do you handle this difficult condition in resource-limited situations, especially in Africa? That's his first question. I think the second question, I'll come to the second question because they are not necessarily related. Um, what is your response, Doc?
Um,
Or any comments, maybe?
Yeah, I think it's more of a comment. I don't think there's a black and white answer, but I think it's obviously looking at the overall prevention of getting into a state of sepsis. So remember, if you have to look at the way we were taught in med school, obviously your primary, secondary, and tertiary levels of prevention. So primary would look at your vaccination coverage so that they're not susceptible to getting the disease. Awarenesses that you need to raise in the community, infection control measures, hygiene related, and all those things that will make a healthy 5-year-old or a healthy child in order to prevent getting into the state of sepsis. However, if you are then in the state of sepsis, is then your protocols that come into play. How do we pick it up fast? How do we diagnose and get definitive management so that we have a directed antimicrobial therapy so we can have better control of the sepsis and obviously the control measures that comes into infection control.
Yeah, that's right. I think his second question is he says, not sure if I missed anything, but do we use a fluid bolus in malnourished septic shock children or just normal rehydration?
So unfortunately, it didn't specify, it didn't really dissect into saying malnourished. It just said signs of shock. If you see signs of shock, and I think that's where the discrepancy will come, whether you're using a bolus of 10 mils or 20 mils per kg as a stat, because you're using clinical discrepancy. But you still need, even in a malnourished child, you still need to treat shock because they still hypoperfusing, whether they're malnourished or not.
Yeah. If I may ask this one, in a case of general practice, when would you, when you have a child who's feverish and signs of sepsis, when do you decide when to refer rather than treat yourself? Are there any crude guidelines for GPs to say this one you must definitely refer to a pediatrician or to a hospital?
All right. I think the IMC, there's IMCI guidelines, which is the integrated I forgot management of your sick children. So they have different ratings or triage. The book is even color coded. We used to use it a lot for our awarenesses when it comes to primary healthcare. And I believe when you go to a GP, that's where you're starting. It's just that you're in a private sector, but the same guidelines still applies. So meaning you look at your red flags, you look at the color coded red, orange, and green, and then you see whoever falls within that line then needs a referral. Whoever falls here needs this. I think it's the IMCI. Yes, IMCI guideline.
Okay, great. Thank you. Thank you very much. I don't see any other questions from the floor. Dr. Bikitsha, thank you very much. I think at this stage, I'm going to ask Professor Stempis of LRP, who's a well-known senior academic pediatrician, I think to assist me with a vote of thank you to you and to the audience. Over to you, Professor Velapi.
Good afternoon. Can you hear me, Dr. Kinoshi?
We can hear you quite clearly, Prof. Thank you very much.
Good afternoon, Dr. Kinoshi, and good afternoon, Dr. Bikitsha. And afternoon to the colleagues on the who have joined the webinar. What a great talk, viewer. Thank you so much. Thank you so much for this. And I think this is one topic that is a major killer in children in terms of sepsis. It gets worse for those who are in septic shock. And I think you have given us a nice, detailed, clear presentation on guidelines in terms of surviving sepsis campaign in children. This it's been beautiful. I think it's clearly presented, and I think looking at this topic for us as a country is a major should be taken as a priority, because if you look at the children who die, sepsis is high up on the list, whether it comes through pneumonia or meningitis or septicemia. Is a major problem, whether it's a real disease. At the end, some of these diseases they end up presenting a septic shock, and it's worse in neonates, where the mortality is even much higher. I think I like here the statement number 13. I think that needs to be highlighted. That when you don't have a pathogen, stop antibiotics, and as soon as that, I mean, if the patient's clinical has improved. And I think sometimes we tend to forget as clinicians, we go beyond the duration, and that increases the risk of developing resistance. So I think that statement 13 to me we should keep in hand. And I think the approach of bolus versus inotropes or vasopressors, I think it's a good one to say. Some studies are saying yes, some studies are saying no. So I think the guidelines are clear on that. I think if you look then at the challenges that we face in the country is the multi-drug resistant organisms. And I think one of the statements that they make is that where you're dealing with immunosuppressed children or patients with immunosuppression, and I suppose a group of neonates have got immunodeficiency, not because of suppression, because of their development. They say must consider to cover multi-drug resistant organisms where those are common, which is often a challenge, because if you started those and you use a lot of those, you want to develop resistance even worse. On the other hand, if you don't start, you might lose the child. But I think we should always be cautious in terms of using those drugs. If we start them, then we stop them as soon as possible. And I think if you look at the children with septic shock, the mortality is about 10 to 15% in high-income countries. But in low-income countries, it goes up to 35%. But in neonates, it's even worse. Once you have got septic shock, you're looking at mortality 40, 50%. And I think you also highlighted the follow-up that after discharging these children with sepsis, we need to follow them up, because they can have impairment in terms of neurodevelopmental wise, in terms of cognitive function, and including hearing and speech. So 25 to 40% of neonates will have some impairment at about 18 to 24 months, those who are sepsis, and that number is higher if you've got sepsis plus meningitis. So thank you for this wonderful talk, and this is very important. I think people can go back and revise this look at these guidelines again as they manage these patients with shock. And I think it's hot from the press. So thanks to Clinix for bringing this to the fore, so that we can go and look at these guidelines. And thanks to the listeners, and thanks to all those who have asked questions and commented. We really appreciate that, because we need that communication as we have this kinds of discussion. There was a question as to how early does infection show up, sepsis show up, or signs of sepsis show up after the infection. I think you have answered correctly. It depends on the bacterial count on the source of an infection and on the site infected, on the organism that is causing the infection. If you have a group B strep infection in neonates, within 6 to 24 hours of those patients can present with sepsis. You deliver them well in 6 hours. They are dying in your hands. So it can happen very, very quick. It varies from an organism to an organism. Whereas a coagulous negative staph might be a needling kind of infection that shows up a couple of days or hours down the line. So thank you so much. Thank you so much, Dr. Bikitsha. And thanks, Dr. Kinoshe and Clinix for hosting these webinars. Very, very important and very, very educative. And will bring us the great aspects and the beauty about it is all the local speakers from the country, homemade, homebrewed. Thank you so much. Thank you, Dr. Bikitsha.
Thank you very much, Prof.
Good evening to everyone.
Good. Thank you very much, Prof. And I think I personally salute all pediatricians, yourself and your colleagues in pediatrics, because you're taking care of our future. Our children are our future. If you think about future of this country, future of this world, future of our families, it's our children. So we need to make sure that they grow up well-nourished, disease-free, and also, as you say, without any sequelae from any illness that they suffer from. It's very important. So I always salute our pediatricians. Thank you very much, Prof. I see there are more questions coming up in the chat box, but since we have closed, what we'll do, all the questions in the chat box at Tolakele, we will put them to Dr. Bikitsha, and she will respond at a time within the next few days to all those who've asked questions beyond this point. You can just write also to Clinix, webinars@clinix.co.za, webinars@clinix.co.za for any comments that you may have. And thank you very much to you, and have a good evening. We meet again next week, Thursday, at the same time, same place, for yet another great webinar presentation. A good evening to you all.